Thank you, Ganesh, for the kind words and a lot of known faces in the audience. And I'm going to talk on intravenous therapy, more of personal experiences as well, with some improvisations. So we all know that erectile dysfunction, though it is a laughing matter and butt of jokes, but it is no laughing matter. Approximately 10% of the global population, you can say that the incidence is of the erectile dysfunction. There is high prevalence of coronary artery disease and diabetes and related vasculopathies and neuropathies, leading to increased incidence of erectile dysfunction in India. Indian population has high risk factors such as particularly the urban setting, because rural people, they don't have any sedentary lifestyle, though they might have an erectile dysfunction. Obesity, smoking, alcoholism, hypercholesterolemia are few. The prevalence of erectile dysfunction increases with each decade of life, with the lowest prevalence in the 20s age group to highest prevalence in above 70s and more so in the 80s. And if you are lucky enough to get a patient of 90-year-old, then they might have higher incidence. So, to hold and to have is one of the modern vows. Marriage is dissolved. Just Dr. Bhatt covered the potency certification aspect, which is important in nullification of legal, as a legal document in nullification of the marriage. So, common causes of erectile dysfunction are organic EDs. Of organic ED is diabetes mellitus, cardiovascular disease, psychiatric illnesses, hypertension, drugs like antipsychotics, antidepressants, beta blockers, most culprit. Even now I see many practitioners advising propranolol because it is one of the widely used beta blocker and one of the most common reasons for erectile dysfunction. Newer anxiolytics, hormones, anti-androgens. So you also, premature ejaculation is a component of erectile dysfunction. Then quite a few unconsummated marriages, at least 10 cases in a week. Not in a week, in a month. Alcoholism, psychogenic ED, again in less than 40. I like to categorize ED in less than 40s as a psychological reason of erectile dysfunction, and above 40 it is predominantly organic reason for erectile dysfunction. Then less commonly, which I have seen, is post-pelvic surgery erectile dysfunction like radical prostatectomy. Then you have Peyronie's disease. And you have rare cases like multiple sclerosis, spinal cord injuries, paraplegics, venous leaks, post-implant penile implant. Couple of cases post-penile implant. So the various treatment modalities that we are all aware of, the primary treatment is the post phosphodiesterase 5 inhibitors. Then you have combination of phosphodiesterase inhibitors where the single phosphodiesterase inhibitor fails. Typically where you give a short acting like sildenafil and a long acting like tadalafil. Intracavernous injections with vasoactive drugs, which I am going to cover in great detail, and the others like vacuum erection devices and penile implants. Briefly, indications for phosphodiesterase inhibitors: failure of combination therapy, failure of single phosphodiesterase inhibitor, ICIVD, unwilling, contraindicated, middle age, diabetics, all antipsychotics, antidepressant, post-pelvic surgery. Adverse effects like headache, which is most commonly seen with sildenafil because of its higher activity on phosphodiesterase 1 isoenzyme apart from phosphodiesterase 5 inhibition. Then you have rhinitis and cutaneous flushing with almost all the phosphodiesterase inhibitors. You have myalgia with tadalafil because of its action more on the phosphodiesterase 11 isoenzyme. And you have blurring of vision because of sildenafil also having action on phosphodiesterase 6 isoenzyme. The contraindications, absolutely contraindications, is organic nitrates, patients on alpha adrenergic blockers, recent history of MI or stroke, congestive cardiac failure, unstable angina, retinitis pigmentosa. So be careful whenever you are dealing with patients having retinal problems while advising any of the phosphodiesterase inhibitors, more so with sildenafil, because it has more action on phosphodiesterase 6, which is present in the retinal tissue. Then, to begin with ICIVD, the urologist received the importance between two UTIs, prescribed testosterone, and there was no relief, and the patient was sent back to the psychiatrist to deal with. So the patient was like a football, from hitting one goalpost of urologist to the another goalpost of psychiatrist. As per the Freudian theory, the sexuality issues were predominantly of neurotic in origin. However, since 16th century, Varalio and Leonardo da Vinci have proved erection to be a vascular phenomenon, which I do believe, and we all should believe, that it is of course a vascular phenomenon. The advent of intracavernous therapy changed the perspective and management of erectile dysfunction. Now, French cardiac surgeon Ronald Virard, who specialized in andrology because of its inquisitiveness, his interest, inventor of first medical treatment for impotence, designed the modern techniques of diagnosis and treatment of erectile dysfunction. In 1982, he discovered by chance the erectogenic effect of papaverine, where he injected the papaverine directly into the penis, inducing a long-lasting erection, and thus invented the ICI, which is used since 1983. In 1985, the American Urology Association awarded John Latimer Prize to Dr. Virag. His discovery of ICI figured as one of the most important discovery of century in urology and andrology. So whenever the history of penis and its treatment will be written, the name of Dr. Virag will be in top 5. First will be of course, Vatsayana. He got interested in ED occurring in patients affected by Leydig syndrome, where the blood supply to the legs is affected. After observing the effects of papaverine on volunteers, which included himself, the discovery was published in Lancet. From then on, ICI was the reference and means of triggering erection whenever needed to be studied. Today, even after more than 25 years after Viagra outbreak, the intracavernous mini injection remains the most efficient and reliable medical treatment for erectile dysfunction. So this is the publication in 1982. Common drugs used for intracavernous therapy are the first one is papaverine, widely used. Then you have chlorpromazine and pentolamine. Then you have prostaglandin. Other agents which were tried but not commonly used or have not been used are forskolin, sodium nitroprusside, and vasoactive intestinal peptide. Then you have guanylate cyclase activators, potassium channel openers, calcitonin gene-related peptide, which are under investigation. Forskolin, a promising new adjunct, was declared in a publication in 1996, but it is not yet used widely. Then you have similarly intracavernous nitroprusside was shown to be effective, but large dose is needed, so again discontinued. Then the commonly used intracavernous combinations in India they are together like bimix, trimix, and quadmix. Quadmix is not widely used, maybe I don't know who uses it, but I don't use it. Commonly used combinations in India are bimix, where papaverine is added with chlorpromazine or phentolamine. The doses are mentioned. Trimix, papaverine with chlorpromazine or phentolamine plus prostaglandin even. I don't have the number, statistically significant number of trimix double concentrated, where I have increased the prostaglandin E1 dose to double the recommendation, and I have found it to be effective in at least 4 to 5 cases where trimix is not working. So widely used bimix in India, inexpensive, highly efficacious and painless, thermostable in room temperature, minimum long-term adverse effects, minuscule chlorpromazine or phentolamine increases the potency of papaverine by many fold, at least by 10 times. priapism, which should be taken into account, and it should be managed because it is quite common to see in these cases, particularly when you use this modality for psychogenic ED cases. So this is a study where they compared chlorpromazine and phentolamine added to papaverine as a bimix, and they found that they are both equally efficacious. Coming to trimix, it is effective in 50% of cases where a bimix fails, affordable as compared to plain PGE1, more efficacious than bimix. Priapism and fibrosis can be seen in long-term thermolabile refrigeration needed and to be used within 3 months of preparation. So again, 3 different groups: prostaglandin E1, one group; another group, prostaglandin E1, phentolamine or chlorpromazine and papaverine; and another group, papaverine plus chlorpromazine and phentolamine. Of course, they found out that the trimix is more effective than the bimix and other stuff. Indications to differentiate between psychogenic ED from organic ED: to grade the severity of erectile dysfunction, mild, moderate, severe, as a substitute of phosphodiesterase 5 inhibitors; failure, contraindicated; side effects; potency of ICIVD is preferred over. I do have patients who prefer injecting themselves than go for phosphodiesterase inhibitor. Couple of cases is because they don't want the headache, and few cases they want that level of hardness which they don't get with the. Then indication: unacceptable lag period with oral agents, psychiatric illnesses, patient preferring ICVD, moderate to severe organic ED, premature ejaculation in refractory cases. I do get results with this ICVD because the erection is sustained. Post-pelvic surgeries and radical prostatectomy. Short-term use of intravenous vasoactive drugs in treatment of persistent psychogenic erectile dysfunction has been demonstrated in an Egyptian study where they did it on around 150 patients. So again, patient satisfaction and quality of sex life was improved with trimix and prostaglandin E1 injection in this particular paper published in Journal of Sexual Medicine in 2007. So therapeutic dose determination is the most important thing. Psychogenic ED, I prefer to start at the lowest possible dose, 0.05 cc, and organic cases 0.1 cc. Junction of upper 1/3 and 2/3. Privacy and visual sexual stimulation is provided. Responses is compared with the natural sexual response with the help of an erection hardness score. So this is how you do it. Response is graded with the help of an erection hardness score. Penile rigidity is measured with the help of rigidirometer. Dose of bimix trimix is up-titrated till adequate response is seen. So therapeutic application training is given. Training manual, photos, supervised self-injection program. Once convinced with the patient's personality, he is put on home self-injection program, self-assisted, or sometimes we can train the wife also if she is willing. So this is in nutshell: full erection, reassurance, sex education; poor erection, therapy-directed investigations; full erections, but the sexual erection is much less. Interpretation is neurogenic. Then you advise self-injection, vascular, vacuum erection devices, or penile implant. Contraindications: poor manual dexterity, anticoagulants like warfarin and newer anticoagulants, leukemia, sickle cell disorder, thalassemia, seropositive status, hepatitis B, low IQ, and craving for extra hardness. A couple of minutes. So again, there are certain reasons why people withdraw, and they are like pain, which is minimum, unlike with papaverine. Plain or prostaglandin E1 is also quite painful. Bleeding per urethra. Priapism as a bimix is very important. Unless the guidelines are adhered to, priapism is likely. Long-term minimal fibrosis at the end of 100 injection over 3 years period. Tachyphylaxis is very common. Thickening of the injected site. Intracavernous therapy for erectile failure. Impact of treatment and reasons for dropout and dissatisfaction have been already mentioned. As the patient proceeds to home self-injection program, the most important thing we as a practitioner should get the informed written consent for our record, as medical legally it is very important. Then priapism letter for the patient to carry in case of emergency. This is the last take-home message. Intracavernosal, then for priapism you have to give 20 times diluted phenylephrine every 5 to 10 minutes over a period of 1 hour, 100 to 500 microgram per cc. Conclusion, ICIVAD is relevant as ever, 30% failure rates. If done appropriately with right case selection, is an excellent treatment modality. If convinced of this ICIVAD, patient will continue. 5 partners can be involved. Do's and don'ts to be explained, pros and cons to be explained. Ultimately, this is what we seek. Thank you.
Thank you, sir. Thanks for a detailed history of development of ICIVAD and also how to administer it. So the question, suppose if, what is the difference you take, for example, if you give a patient only with papaverine, the other patient with, let's say, a bimix. So what is the chance of priapism risk? I mean, if suppose, let's say, both patients has a psychogenic illness.
Priapism is more with bimix, but plain papaverine needs to be given in a higher dose, and that is quite painful.
In both the cases,
to be honestly, I have no experience with only papaverine. What I have always used is bimix, trimix, and concentrated trimix.
You also said use of ICIVAD for unacceptable lag time. So what is that unacceptable lag time?
Sometimes patients they take Viagra and they have some planned thing. It takes a lot of time. Sometimes they don't get response. They have invested so much in the girl. These particular moments, or in the honeymoon and they have planned something. In those cases, there are few individuals who like this instant erection which they get with the ICIVAD.
Suppose if the patient has used, let's say a PDE5 inhibitor, let's say Viagra or something like that in the last 24 hours, will you still administer bimix in those cases, or you will wait for at least 3-4 days to actually give the
there are two components here. If the patient is responding to...
No, the patient is not responding. He's taken that
one minute, let me complete. If the patient is responding to Viagra, but he doesn't want the lag period associated with it. And there are patients in whom I use short-acting sildenafil kind of drugs, not tadalafil, along with ICIVAD to reduce the dose required for intravenous injections. It gives excellent results.
Dr. Mutha, thank you for your lecture. You said you don't have experience of using papaverine. I have personal experience of using papaverine since 1987, because 83 it came into sort of existence, as you said. Now, I think you have described in detail, but we must know the side effects of all the pharmaceutical vasoactive drugs, and especially I'm referring to
100% we have to be aware of all the side effects. Most common side effect with papaverine first is pain, only plain papaverine, which can be seen with all other side effects, all other agents.
So how do you inject papaverine? I mean concentrated form, because it's a 2 ml injection, which is 60 milligram.
I take a plain Vacutainer, red Vacutainer, plain Vacutainer, and 4 cc of papaverine, I mix 0.15 cc of chlorpromazine or pentolamine, same quantity.
No, pure papaverine.
4 cc.
No, you said you haven't used it, but I'll tell you how to use it, and it is less painful. You have to dilute it with this saline, and the dose you can titrate, but for the pipe test, you usually use more than 30 milligram, more than 1 ml.
30 milligram will be more than
1 ml. Yeah, okay.
So that is a huge volume.
Now, as you said, the side effect is priapism.
Yeah.
So anybody who injects vasoactive drugs should know how to treat the priapism.
That is absolutely.
And I was floored one night when I had injected during the daytime, and we had British nurses in the military hospital, and she said, "Doc, you have done something to this fellow, and he has come to this erection which is more than 6 hours, So I have I'm not a urologist, I'm an internist. But I had read it, that I have to withdraw from the cavernosa musculatura cavernosa. So I withdrew about, the blood and it came down. So there are other modalities you can use. You can exercise, you can divert the tension, but that doesn't work. You can, metaraminol can be injected and all those things. So I'll tell you another personal experience. The first time I injected prostaglandin E1, I think gave 20 times the recommended dose of 10 to 20 microgram. And the fellow collapsed, his blood pressure came down. But being a physician, and I was near the ER, so we rushed him, put him on the drip, and we could revive, no problem. And later on, I realized it is a very small lateral ampule, or the vial, and it had 500 microgram of prostaglandin, anastrozole. So next time I diluted it in a normal saline 100 ml, and the shelf life is 6 weeks. You can use it, you can prepare it. So I think being a physician, and if you are injecting such, you should have a fair knowledge of BCLS and ACLS.
Absolutely.
So you should know how to resuscitate. Secondly, you should be very familiar with the side effects of that. You are using intravenous.
When you are for detumescence, I use phenylephrine 20 times diluted.
Right.
Okay. So when phenylephrine you are using, you are supposed to monitor the blood pressure because the systolic blood pressure can shoot up because of phenylephrine. So you have to be careful when you are doing all this. You have to be absolutely sure about this. You have to be sure that the blood pressure is normal of the patient and it should be under monitoring.
And especially phentolamine, I use it for hypertensive crisis.
Yes.
The first time I was an intern and house surgeon, when we used it for pheochromocytoma, then the BP was more than 250. So sometimes phentolamine, papaverine, and when you give this mixture, they can have transient hypotension. And how to avoid it? When you inject, you must block the base of the penis so that the drug doesn't wash out, and goes into the system.
So that precisely what happens when you get good erection, the blood doesn't enter the system. It is
in the tumescence phase,
Yeah.
after a few minutes,
before
you
and
have to, that's another practical point. And I think we have to salute in the history when you mentioned about Ronald
Dr. Ronald Virar.
Virar, in 1668, Rainer de Graaf, the person who described the Graafian follicles, he worked on the cadavers, and he injected the vinyl vessels with the saline, and he could produce erection in the cadavers, So I think it's very interesting, that in this field, you have to go to the basic sciences, clinical anatomy, clinical physiology, and clinical pharmacology.
I like to say that it is an integration of all the subjects of
Yes.
medicine. It is not one subject cannot claim the authority on medicine.
So unfortunately, when we are mature physicians or surgeons, we rely on the drug or use it as a chocolate, without realizing the basics and the molecule level, Thank you.
The mechanism of action of chlorpromazine enhancing the potency is a 20 times. You are a pharmacologist.
10 times. 10.
What exactly happened? Synergism.
Blocking of the alpha receptors which are there in the genetic tract.
And the other thing is the combination of 5 phosphodiesterase inhibitors plus mucosal prostaglandin. What is your experience?
I have never used the urethral prostaglandin, never. But I have used bimix, trimix with combination along with sildenafil. Not tadalafil because tadalafil has a longer half-life.
As he rightly said, no drug is a chocolate. That's
Of course, but the trend in India is just, overconsumption of chocolates.
that is why we are here.
Good morning, myself Dr. Shashidhar. I'm from Bangalore. When it comes to the incidence of priapism compared to papaverine and the combination of bimix, the incidence of priapism is much higher because of the blocking activity of the CPZ in the bimix. Second thing is just doctor asked that is it wise to do a Doppler test with injectables when the patient is taking Viagra or tadalafil? Because Viagra has a short half-life, we can always do a Doppler test maybe the very next day. But tadalafil, we have seen the incidence of priapism is much higher because of the unpredictable absorption and the you have the concentration in the blood. So it's always better to avoid for at least 72 hours when the patient has taken tadalafil rather than Viagra.
No, for any drug, the washout period should be 5 times the half-life. The half-life of tadalafil is 17 hours, so multiplied by 5 times. So that should be the washout period at least when you are dealing with tadalafil.
And regarding the treatment of priapism, I think always better to go for a decompression with 1 in 10,000 dilution of adrenaline or in the office rather than if it fails, then only I think you should proceed to reduction.
You should be careful with adrenaline.
Yeah.
Adverse effect profile is favorable with phenylephrine. It's a safer drug as compared to adrenaline. Adrenaline can give a sudden systolic high, so you have to be very careful about it.
I agree with Dr. Mutha. I think adrenaline, atropine, etc. should be used with great caution.
Yes.
As a cardiologist.
Absolutely, you have to be cautious.
Now, I think for the 5 tests to document, I don't know, I know it's done with the radiologist, but you should know to read the systolic velocities, and how to diagnose.
Sir, I prefer the specialist. I don't do this sonography and
No,
all.
I'm not saying you know it, but I think when we are discussing about the pipe test, this is, the venous leak can be differentiated on the diastolic velocity.
No, but very few understand these things. Sir. Even if they are radiologists, very few can understand this penile Dopplers and the right thing to do, in my experience, because it definitely needs a lot of dedicated work. A general radiologist cannot do justice to the Doppler test
It's
of.
only measuring the velocity in the cavernosal arteries and easily focused with 7.5 megahertz probe. And the diameter after the stimulation, the diameter change, and it's not that difficult.
Probably you have done it many times.
Yes,
You are quite
I agree with you.
Yeah.
Okay, thank you. Thank you.
కొంచెం పిన్నాడి